Yeah, please start. Please start.
Thank you, Shubham. So, good evening, everyone. And now we'll be starting our 20th webisode. So we started this program approximately 9 months ago, and the idea was to impart education about gastrointestinal and hepatobiliary cancers to everyone. And we are very, very enthused with the kind of response we have got. And this is our 20th episode. And we've so far discussed pancreatic and periampullary cancers, neuroendocrine tumors, liver and liver hepatic cancers. And this series, we are discussing stomach cancer. So we welcome Dr. Chandramohan in helping us with understanding of gastric cancers. And Dr. Chandramohan is a professor of surgical oncology at RCC Trivandrum. And then we have as moderator Dr. Subhashish Das, who is a GI-HPB oncosurgeon at Max Vaishali. And we also are joined by Dr. Rajesh Panwar and Dr. Saleb Harris and Dr. Shaifali Goel. So we welcome you all. And with this, I would request Dr. Chandramohan to take us through the intricacies of gastric cancer.
Thank you, Dr. Nikhil. And it is a heartening experience for me to come and talk to you guys. In fact, I think one good aspect of COVID is that the number of meetings, online meeting has grown significantly, and a lot of knowledge exchange is happening all across the country. And I think that is being reflected in improving standard of the exam-going students, especially national board examinations. The quality has gone significantly, and also in teaching centers doing MCA surgical oncology, the number of teachers are not good. The students are now improved a lot. That is my observation as an examiner this year and last year. And I really thank people doing such meetings in a regular basis. Coming to this topic, the stomach cancer, anatomy and surgery. Yesterday I had a meeting arranged by the Ahmedabad ASI and also some teams, including Ludra in Delhi. And the same topic I had to talk about a lot of surgical principles and the lymphadenectomy, etc. So, and I always feel that I should not be repeating the slides twice. So today I am, as the organizers requested, I'll be talking more about anatomy and how the anatomy knowledge is getting translated into better surgical care. We all know that stomach is an organ which is hidden in the costal cartilage in the upper abdomen, and as a surgical trainee appearing in examination, a mass appearing in this region should be three organs, mainly liver, stomach, or colon. And of course, there are retroperitoneal organs which is behind these organs, which are pancreas. So the location of stomach is very peculiar. And if you see a case in examination, the diagnosis is mainly by the dyspeptic syndrome, obstruction, as well as the clinically palpable lump in the particular location. Coming to the embryology, I think the knowledge of embryology is very, very important in surgical for a surgeon. There's a funny thing which is happening at the foregut is rotation. Rotation happens in two directions. From the primitive mesogut, the liver, spleen, stomach, everything arises, and then some kind of rotation happens. The omphalomycentric tract rotate in a clockwise manner, and also the stomach tube is rotating again in a clockwise direction. So because of this, what happens is the things which is located anteriorly are moving towards the right side, that is lesser curve, and stomach, the tube, things which are located posteriorly are moving towards the left side, that is greater curvature. The importance of this is, if you think about the rectal cancer or colonic cancer, the excision of the mesentery or mesorectum is very important. So if you consider the embryology and think which should be the mesentery of the stomach, it should be the greater momentum. So I'm coming to in detail about the various controversies in management of bladder momentum in my later slides. Again, stomach has two sphincters. One is cardiac sphincter and at the proximal end, and pyloric sphincter at the bottom end. And when you do a proximal gastrectomy, what happens is one of the sphincter is gone and second sphincter is active. Because of this, a lot of reflux will happen into the mediastinum. Not only that, in a proximal gastrectomy, because of the lack of clearance of the adequate nodal stations located distally, the recurrence rate is high. So any proximal gastrectomy is not an oncologically sound surgery compared to the total gastrectomy, and it also has a myriad of symptoms which include a reflux into the esophagus. Coming to the blood supply of the stomach is deriving blood supply from a lot of vessels, and it creates a lot of confusion. In fact, the lymphatics and cancer cells spreads along the vessels. So this wide spread of blood vessels in stomach, in arterial as venous supply, causes dissemination of disease into regions which you don't expect in other organs. For example, a tumor located in the upper stomach, it can go towards the diaphragm, it can go towards the spleen, and then it go to the pareatic and thoracic duct. A tumor located in the lower part of the stomach either can go through up the upper pathways into celiac axis and pareatic area, or from the lower pathway it can go direct down into the retropancreatic area as well as the superior mesenteric nodes. So because of this, if you plan a lymphadenectomy, it has to be different for different locations. And another alarming thing about the upper gastrointestinal tract is variation in the blood supply. So if you think about the left gastric, which is most commonly variable, and many times the left lobe of liver will be supplied with left gastric artery. And I think the incidence in my practice is very, very high. Many times I have to preserve the left gastric and only going to hepatic and only sacrifice the stomach margins by doing careful lymphadenectomy and dissection. And left gastric can also arise from the hepatic, the right hepatic, or even sometimes from the gastrosplenic trunk, or sometimes from the aorta directly itself. Similarly, the right hepatic, right gastric can arise from various sources, including directly from aorta or superior mesenteric artery. And another variation is the variation of the right hepatic artery. Many times, right hepatic artery will be coming from the superior mesenteric artery. So when you try to do a lymphadenectomy along the right hepatic artery, unless you have done a previous CT angiogram and very sure about the location, you'll be confused on the table. So I think if as a part of the preparation of a surgical procedure, other than the staging and anatomical location of the tumor in a CT scan, we always look at whether the vessels are replaced or anomalous before planning a surgery, and that is very important part of the surgical planning. This I have already discussed. Again, venous drainage is slightly different in that the arterial supply mainly comes from the celiac axis, but the venous drainage goes directly to the SMB. So the stomach can be classified into various units, and for the surgical planning, it can be cardia. Cardia is the area where esophagus joins the stomach, and the area above this line of cardia is called fundus, and then body and pylorus and pyloric canal. For comfort, I think the West has divided the stomach into various gastric unit. The proximal gastric unit as well as distal. The proximal gastric unit is cardiac, fundus, upper body, and the distal is gastric antrum, pylorus, and first part of the body. But Japanese classification is slightly different. They have classified the stomach into 3 regions: upper, middle, and lower, exactly based on the distance from both lesser curve and greater curve, dividing into thirds. Another issue is defining OG junction. OG junction is anatomically, radiologically, surgically, and endoscopically variable. And I'll come to the classification of OG junction later. Histologically, it is accepted as the boundary between stratified squamous columnar and columnar epithelium. If you look here, you can find out that the anatomists define this OG junction at the lower part of the diaphragm, and the surgical division is slightly above, and the radiologists find little down based on the radiological landmark, but endoscopically this is high based on the palisading vessels or the squamocolumnar junction or the end of columnar epithelium. So Z line is usually considered as the mark, the border between the gastroesophageal junction as well as stomach. And again, the Sievert has classified it into type 1, type 2, and type 3. Type 1 is 5 centimeter above the OG junction up to 1 centimeter above it. Type 2 is 1 centimeter above the OG junction to the 2 centimeter below it. And type 3 is 3 centimeter below the OG junction to 5 centimeter below it. And but the recent AJCC classified it into either stomach cancer or esophageal cancer. And the tumor which has epicenter either in the esophagus or within 2 centimeter of the OG junction in the stomach is considered as a esophageal cancer, while the epicenter is distal to that, it is considered as a stomach cancer. This classification is very important in planning a surgery as well as lymphadenectomy. Now comes the importance of omental bursa or lesser sac. The omental bursa is the area situated behind the stomach, and it is bordered anteriorly by the quadrate lobe, and to the left by the left kidney, and posteriorly by the pancreas, and to the right by the ecpiploid foramen. And it is thought to be a very important organ limiting the tumor spread. The existence of the omental bursa intact was considered as a sacrosanct principle of a D2 gastrectomy until the laparoscopic surgeons challenged it, because it is very difficult in laparoscopy to clear the bursa intact. Then a number of trials were conducted, whether looking into each component of gastric D2 dissection, like removal of the omental bursa, and they found out that a JCOG trial looked into this aspect, and the trial concluded that there is no added advantage in doing vasectomy along with the omentectomy. So I think the surgeons should be doing endoscopy as well, and they should be well versed with the endoscopic anatomy, because even in order to plan a surgical resection or a surgical bypass, you have to know where the tumor is located. So if you look into endoscopy, you can see this kind of picture. In an area, you see a lot of rugae. No, you can't decide on the location based on the whether it is anteriorly or posteriorly, because endoscopes are something which rotates and keeps on changing. So if your assessment should be based on rugae. When you see the gastric rugae affords, it is going to be the greater curvature, and the thing opposite is going to be lesser curvature, which is less no rugae. And the thing which is once you know the greater and lesser curvature, you can easily guess which is anterior and which is posterior. So this knowledge is very important. And once you have a tumor located in the proximal stomach, it is very difficult to visualize it unless you go and do a retro maneuver called J maneuver. And when you do endoscopy as a part of the surgical workup, the biopsy, traditionally it is said that you have to do at least 7 punch of biopsy, and the exact location of the stomach has to be noted, and the distensibility has to be noted. Suppose the stomach is not distending well, it suggests a cancers, aggressive cancers or liniasis plastica. And many times biopsy may be negative. Then you have to do a well biopsy, like repeatedly going in the same area to take a biopsy. So these things are important in surgical planning. Again, if you look into the picture, you can see that the area which is having rugae is the greater curvature, and the opposite side, which is smooth, is lesser curvature. And if you go little more distal, you can see the incisura on the lesser curvature side. Endoscopic ultrasound is an important tool in armamentarium in managing stomach cancer. It is very, very important to do endoscopic ultrasound to find out the T stage and N stage. Anything which is less than 0.8 mm in size won't be picked, a node won't be picked up by a CT scan. For that, to classify whether it is T2 or T3 or T1 or T2, you need this endoscopic ultrasound always. CT can't do it. The accuracy is bit high, 64 to 92%, and for T stage, and 50 to 90% for N stage, much above the CT scan. And once the importance of identifying the T2 or T3 or N plus is, according to the most recent guidelines, these are the patients who should be subjected to neoadjuvant protocols. So the use of endoscopic ultrasound in finding out the correct T stage and N stage is recommended by most of the guidelines. This is an endoscopic ultrasound picture, which shows pretty much even small abnormalities as well as lymph nodes. And one more thing I like to reiterate here is as a workup of a patient for a gastrectomy, especially when you deal with a little locally advanced or other than early cancer, it is always recommended to have a diagnostic laparoscopy, because the laparoscopy will pick up 30% more lesions in the peritoneum, etc., which is not picked by the CT scan. The recent study we did in our institute, the pickup rate for laparoscopic ultrasound in otherwise non-metastatic CA stomach was 40%. The ligaments are very, very important in stomach. Actually, ligaments are holding it all across. You have a hepatogastric ligament which goes from the stomach to the liver, and it contains the right and left gastric artery and a lot of lymph nodes. And there is a hepatoduodenal lymph node. The dissection of the hepatoduodenal lymph nodes, ligament and lymph nodes are important in D2 gastrectomy, where you see the proper hepatic artery as well as lymph nodes. Then you have the gastrophrenic ligament, which contains short gastric arteries. So if you are planning a distal gastrectomy, this short gastric vessels has to be saved to have good vascularity for the liver, stomach. And then you have the gastrosplenic ligaments, which will also contain short gastric vessels as well as lymph nodes. And then comes the gastrocolic ligament, and this has to be lifted along with the greater omentum, which is going down for a complete clearance of the lymph nodes as well as the adjacent tissue. And then you have the duodenum. So again, applied anatomy, what you should be knowing that the stomach cancer can spread through these ligaments without coming to the visceral peritoneum. Then still it is considered as T3, not T4. And regarding the stomach cancer spread, it can spread through this ligament. It can spread through lumen also. It can spread into the esophagus as well as the duodenum. The spread to esophagus is much common than the spread to duodenum. And the duodenum, it spreads via the subserosal pathways. In duodenum, in esophagus, it spread via the submucosal pathway. And coming to the greater omentum. And the greater omentum, as I mentioned in my anatomy slides and the embryology slides, this is something which is the equivalent to the mesorectum. So till now, the whole excision of the greater omentum is considered as the sacrosanct part of the gastrectomy for cancer. But again, with the growth of laparoscopy and robotics, a lot of people have challenged, because removing the entire omentum intact is little difficult in laparoscopy. So there a lot of dilution have come, and people have looked into the oncologic importance, whether any advantage for the existence of omentum. And if you look into the guidelines, you say that ESMO doesn't give any advice. And American guidelines say you have to resect both greater and lesser omentum. And Japanese guidelines, I think, little more applicable to us. It says that T1, T2 preservation of more than 3 centimeters of the gastroepithelial arcade should be done. And T3, T4 only, they are advising a total omentectomy. Again, there are no big studies, but many small studies. And this particular study, which is of interest, it came in BJS 2016, suggests there is omentectomy may be omitted. It's Omega trial. And another trial, which came later in Journal of Gastroenterology Surgery, they say that omentectomy should be done. So I think the researches are divided. Again, there is another publication which is published in World Journal of Surgical Oncology. They said partial omentectomy is oncologically safe. So this all show that we are in a mixed opinion. And coming to lymphatic drainage, which is very important aspect of the stomach cancer management. As I described, it has 4 major routes. Either it goes to the superior gastric, suprapyloric, inferior gastric, pancreatosplenic. These are the 4 routes I described in my beginning of the talk. And Japanese has divided this into various lymph node stations. So this is a very complex Japanese guideline. With I am not going into the details of this. Basically, what you have to understand is that the lymph nodes are divided into 3 echelon nodes. The first is perigastric nodes, and second comes the nodes along the vessels like left gastric, celiac axis, hepatic artery, proper hepatic artery, common hepatic artery, and next tier of lymph nodes of the vessels, lymph nodes beyond that, then those come into the behind the pancreas, retropancreatic node, superior mesenteric nodes, as well as the other nodes. So a lot of research trials has gone and examined the utility of lymphadenectomy, D2 lymphadenectomy. And as you all know that all the Western trials fail in showing advantage, but the reason is not that the D2 is bad, because the extremely high morbidity which is happened after the D2 lymphadenectomy, and it has happened even after D1 lymphadenectomy. If you look into MRC trial or Dutch trial, you can find out that the mortality with even D1 dissection was something like 5 to 6%. That is unacceptably high, and the mortality of the D2 lymphadenectomy arm was something which is up to 13%. This is also unacceptably very high, and the long morbidity of D2 arm was nearly 46%. That's also unacceptably high. So because of these reasons, and also because of the inclusion of splenectomy and pancreatectomy, most of the Western trials failed. But even then, the world now thinks that D2 gastrectomy is the standard of care. But unfortunately, that is not recommended in NCCN, or that is given as an optional thing in ESMO guideline. But the Asian and Asian world, as well as Indians, believe that D2 gastrectomy should be done as far as possible. Again, the D2 gastrectomy is variable according to the location of the tumor. And in between, we have one thing called D1 plus. So in D2, for a total gastrectomy, D1 is removal of 1 to 7. Mind you, this is Japanese guidelines. And D1 plus, along with that, you remove 8A, that is hepatic artery node, and which is located anteriorly, 9 celiac axis nodes, and 11P, which is the proximal splenic artery nodes. And in D2, along with this, you have to remove the station 10 also. But the latest Japanese guidelines don't advise removal of the station 10. Station 10 need to be removed only when you have a tumor located at the greater curvature, or you have a positive or positive looking or frozen positive for SB node. Otherwise, no need to go and do the splenic node, which is station 10. And regarding splenectomy, most of the surgical groups are now advising the station 10 lymph node removal without doing a splenectomy. That's also very important. Again, for a distal gastrectomy, certain lymph node stations like 2 is omitted, and even in D1 plus, the 11P is omitted, and in D2, 11D is omitted. It's a little compromise. Based on the anatomical knowledge, which I mentioned in the beginning of my talk, the more caudally located lesions, the lymphatic spread go to the celiac pathways as well as the superior mesenteric pathways. So no need to go behind to this left upper abdominal quadrant and remove the splenic nodes, the distal splenic artery nodes as well as the level 2 nodes. So your dissection should be more towards the distal part and the right part. So that's what you need to, in distal gastrectomy, you don't remove the splenic nodes, the distal splenic artery nodes, etc. And then come pylorus preserving gastrectomy. Pylorus preserving gastrectomy is not, Japanese say this is a non-standard operation, because it is, there is no D2 in it. It is only D1 plus. Where the pylorus is preserved, but I have, yeah. So this is proximal gastrectomy, which is also, in the beginning of my talk, this is, I said that it is a non-oncological recommendation. It is a non-standard operation as per Japanese classification, and it has, because of lack of addressing the distal lymph node stations, the results are bad, and because of the loss of upper esophageal sphincter, the lower esophageal sphincter, a lot of reflex comes and stenosis comes. So this is not ideal to be recommended. You can do only in a compromised patient where you can go higher up into the mediastinum and clear lymph nodes. So coming to the margin, this is very important. When again, you can't say about stomach cancer margin without going into the subtypes. Just as we all know that stomach cancer is basically a diffuse type, which is infiltrating, where you have longer margins, or it is intestinal type, which is we have lesser margins are acceptable. And there are other understanding also which is coming up in terms of the molecular classification of stomach cancer. But as if now we don't have separate margins for various molecular classification. So what you have to remember is the only concern is is about proximal margin. The otherwise, by doing a total gastrectomy instead of partial gastrectomy, you can pretty much get a good margin. But don't worry about the distal margin. A distal margin as small as 2 cm or even less can be accepted. Only thing is that you have to go into the first part of the duodenum and cut it there. And coming proximally, especially in the upper part of the stomach, the margin is very, very, very important. When you have a early cancer, well-differentiated cancer, 2 to 3 cm margin is acceptable. But when you have a poorly differentiated cancer, diffuse cancer located in the upper part of stomach or cardia, go for a 5 cm margin. If that necessitated doing an esophectomy also, please do it, because that is worth it. I think that is my summary. And one more thing is regarding the surgical management. The 2 kinds of standard surgical operations are acceptable. One is total gastrectomy, other is distal radical gastrectomy. So these are the standard operations as per the Japanese guidelines. When you do a distal radical gastrectomy, the results are at par with the total gastrectomy oncologically. Not only that, functionally, it has a better quality of life and less stenosis. So this is in short about anatomy of the stomach cancer. Thank you very much. You are not audible. Can you unmute? You are not audible. Yeah, now it's feebly audible.
Okay.
You're not audible, Nikhil sir.
Am I audible now? Am I?
The voice is
Yeah,
breaking.
the voice is breaking.
Subhashish, can start the panel discussion.
Yes, and now you're audible.
Yeah.
Okay, sir.
And so, do we have any questions? There is one question in the chat box. What are the indications of vasectomy? Dr. Asit is asking.
Yeah, vasectomy was considered as a sacrosanct part of the D2 dissection. So vasectomy is part of D2 dissection, but the JCOG trial has shown no separate advantage for doing vasectomy. So if you are an open surgeon, I think you should do a vasectomy for all cases of deep dissection. But if you are a laparoscopic surgeon, you can omit it if you want.
Okay. And okay, Dr. Amsa has asked which vessel to be tied for proximal gastrectomy.
The right vessels, except the right gastric and right gastroesophageal vessels, you can ligate all of the vessels.
Correct. So, Dr. Chandramohan, do we do proximal gastrectomy these days?
Yeah, actually, in my institute, many patients used to undergo a proximal gastrectomy in the past. And in fact, I have, especially for OG junction tumor, where the surgeon is not comfortable in or not happy or not ready or assess that stomach won't reach neck or thorax, then as a compromise. And also in compromised patients, a good number of proximal gastrectomies have been done in past in our institute. And when we looked into the oncological outcome recently, we analyzed 122 patients operated with the follow-up of 5 years, and we have found out that whenever the margin got less proximally, it recurred. And so 2 to 3 centimeter margin, even 2 patients recurred 2 to 3 centimeter margin. And whenever we did a proper proximal margin and esophageectomy, including McKeown are having the best results. Those people who are, when we made a stomach tube and anastomos neck, the distal margins are not issue. The McKeown is having best results. So there are centers doing proximal gastrectomy, but I don't think it is recommendable as a oncologically safe surgery. It should be a compromise.
Correct. I hear that. And Dr. Thakur has asked that extent of surgery in lymphoma. So do we take that question?
Yeah, sir. No, yeah. Lymphoma doesn't need surgery, only gastrectomy.
Yes. And Dr. Amit has asked, what is the anatomical landmark on the stomach for transection in distal gastrectomy?
Yeah, so the various landmarks are there. If you look for the branch of the left gastric artery, the first branch of the left gastric artery, you start ligating from there. And the sacrosanct principle is a good margin. So if you're preserving the vessels proximally, I think the only thing you have to be worried about having a good 5 centimeter margin, and whether the other things are of secondary importance.
So, I mean, Dr. Chandramohan, I would just slightly modify this question. Do we have actually some anatomical landmark, or do we have our proximal margin depending on the extent of tumor in the distal stomach? We just need a margin and a good lymphadenectomy. So the proximal transection margin could be anywhere.
See, basically, what any bowel related malignancy, there are 2 things which decide. Rather 3 things. The number 1 thing is the extent of the disease spread you expect through the lumen. For example, if you are managing a diffuse gastric cancer, you expect it to go along the lumen little more, especially submucosally. And number 2, the extent of lymphadenectomy is needed. And many times, that is why the proximal gastrectomies failed, because it didn't address lymph nodes along the right side of the stomach. That is the second concern. And the third concern is whether the bowel will be viable with the vascularity. And I don't think the viability is a great concern for stomach cancer. So these are the 3 principles, and where you restrict on the margins.
May I add something here?
Yes.
Yeah,
Yes.
Dr. Rajesh, please.
So the landmark for a distal would be that you leave behind most of the short gastric. You may tie 1 or 2 on the greater curvature, because you want to remove epiploid lymph nodes left chest in the distal gastrectomy as well. And you want to remove 1, 3, and 5. So you'll have to go higher up on the lesser curvature. So you divide the stomach 1 to 2 centimeter distal to the esophagogastric junction on the lesser curvature, and then you tie off the left gastroepiploic, and at that point you divide. And you want a margin of around 5 centimeters because we get huge tumors. So we can go more proximally, and we may do a subtotal gastrectomy also, where you tie off more short gastric. And there is a case for near total also, where you tie all short gastrics and you just leave behind a pouch of stomach. So all those are there, can be modified accordingly. But the main thing is that you have to achieve a negative proximal margin.
Yeah,
so the division will depend on that.
One more thing I will add on to it. When you are doing a proximal, the distal gastrectomy, you have to clear the entire lymph nodes along the up to the esophagus. Entire lymph node has to be cleared.
That's on the lesser curvature. Yes.
That's very important.
How much stomach we can leave on the lesser curvature side after we have cleared all the lymphatic tissue from the lesser curvature? So that if we bear that area on the lesser curvature side, I don't think we can leave more than 2 centimeter margin over there.
1 or 2 centimeters of the syndrome. If you go higher up, then there is a chance that we might narrow down the piece of esophageal.
No, I'm asking what maximum we can leave, because vascularity will be an issue, because the vascularity on that wall will be coming from the esophageal side.
You won't be able to leave behind more than 1 to 2 centimeters.
Correct. So that is the medial margin, and laterally we can leave as much as we want.
Yes.
Subject to the lymphadenectomy stations required, correct?
And you don't want to go higher than that, because in that case, then you'll have to put in a bougie before dividing, so as to ensure that you don't have a narrowing at the esophagogastric junction. It's very easy to fire a stapler on the esophagus if you're not careful. The stapler can go into the esophagus and then there'll be narrowing at the junction.
Absolutely.
So we don't want that also.
Okay, so we have that point clear. Do we have more questions? So I guess none. So in that case, we can move on to panel discussion. My dear colleague, Dr. Subhashish Das will now take it forward.
Sir, thank you, sir.
One more question has come, sorry. What's the approach to lymphadenectomy in case there is a replaced left hepatic artery arising from left gastric artery? Interesting question.
I think Chandramohan already mentioned this in his presentation.
I missed it. Okay.
Yeah.
So we can just take that again. Dr. Chandramohan, please.
We used to ligate it and nothing happened. But now we are a little reluctant in ligating because a lot of patients are having with liver issues and NASH-like symptoms are coming. And now most patients are receiving neoadjuvant chemotherapy and their liver is not looking good. So we are trying to preserve it. I think especially with the laparoscopy, if you are a laparoscopic or robotic surgeon, you have fantastic dissection of the entire artery, preserving it. But if you feel like it is resectable, I mean, you need to be sacrificed, you can sacrifice as well.
Okay, fine. So I think Dr. Subhashish now can start with panel discussion.
Thank you, sir. I'm just sharing my screen.
Yes.
Is it visible, sir?
Yes.
Yeah.
I'm Dr. Subhashish Das. I'm an associate consultant in GI and HPB Surgical Oncology, Max Institute of Cancer Care in Vaishali. First of all, I would like to thank Dr. Chandramohan sir for this nice and brief description about the embryology, anatomy, and surgical aspects of CS stomach. So without wasting any time, I'm going to conduct a panel discussion, moderate a panel discussion on carcinoma stomach and the related surgeries. Now, gastric cancer, as we all know, it ranks 5th in incidence worldwide, according to latest Globocon 2020 data, and it ranks 4th in cancer-related deaths. The most notable finding has been that.
Okay?
Sorry, sir.
No, Dr. Subhashish, please continue.
Yeah. So most recent notable finding has been there is an increased incidence in young adults, that is less than 50 years, especially in Indians. Now in the West, the incidence of gastric cancer has decreased, has been on a decreasing trend since last 1 decade. India, however, falls under a lower risk of gastric cancer countries. And in India also, if we see, the highest incidence has been found in northeast part, followed by the southern part. Now, gastric cancer stands as the second most common cause of cancer-related deaths among Indian men. As we all know, the only chance of cure in carcinoma stomach has been complete surgical resection, plus or minus neoadjuvant or adjuvant chemotherapy. Despite this fact, what was earlier believed that a curative gastrectomy actually cures the disease, still then, despite this fact, this disease has a tendency to recur in majority of the patients. So nowadays, the focus has been on developing effective pre and post-operative systemic and regional, that is neoadjuvant adjuvant therapies. And luckily, we worldwide, we stand to a certain protocol according to the even NCCN guidelines or Japanese guidelines. So we are following the standard neoadjuvant and adjuvant therapy in cases of carcinoma stomach. So without wasting any time, we'll just go to the case capsule. This is a 54 years female of BMI 45, ECOG performance status on 0-1. She presented with complaints of new onset dyspepsia. Since last 3 months, there was no history of upper GI bleed, hematemesis, or melena. There was history of loss of weight and appetite. So we did an upper GI endoscopy, which showed this antral ulcer with everted margins, and the biopsy of which showed poorly differentiated adenocarcinoma. So we tried to stage the disease with a CT scan and then PET CT. So PET CT showed there has been a circumferential mural thickening involving the antropyloric region with multiple avid perilesional nodes. So most likely the clinical stage of this patient was T2, T3, and N+ disease. Now, Dr. Chandramohan sir, please can you tell us what will be the next thing in this patient? What is the next thing to be done?
Thank you. First of all, in this patient, I expect and I suppose there is no other lesion other than this index lesion, which is at the antrum. And the CT scan is not showing any metastasis. The next thing should be to plan the therapy. And believing the PET scan, I think it is N+. It is N+ nodes. So this patient need to have a neoadjuvant protocol. But before that, I like to subject the patient for a diagnostic laparoscopy as well, because the 30% of cases are going to be missed by the CT scan and PET scan. And 30 by CT scan, 50 by PET scan in peritoneal metastasis. So I like to do a diagnostic laparoscopy first and proceed.
Thank you so much, sir. Dr. Rajesh, do you do diagnostic laparoscopy routinely before starting any sort of neoadjuvant chemotherapy? Dr. Rajesh, sir?
Yeah, you should do, especially this patient, because there are already lymph node positive on PET. Here, I think you should do a staging laparoscopy before starting any treatment, because some of these patients will have metastasis and they'll progress. It will be unnecessary neoadjuvant protocol. And the yield of laparoscopy in these patients is up to 30%. So you can avoid unnecessary treatment in those 30% of patients.
Thank you so much, sir. So here I have some slides after a couple of slides about this diagnostic staging laparoscopy. Now, as we thought, so we have had a tumor board meeting and we decided to go ahead with a neoadjuvant chemotherapy. So we did given the patient 4 cycles of FLOT, and then a restaging PET CT was done. So even the NCCN guidelines also support, as we can see, this CT2 or higher disease or any of the lymph nodal positive disease. Perioperative chemotherapy is actually the standard nowadays worldwide. So now this question, which Dr. Chandramohan sir has already answered. So this staging laparoscopy, I just wanted to ask whether it should be given pre-neoadjuvant or pre-surgery, or both the settings?
Both.
I'll go for both.
Both. Dr. Shaifali, do you also follow at Rajiv Gandhi Cancer Institute this protocol?
Yeah, we also follow the same protocol. We subject the patient to diagnostic laparoscopy because most of the patients have poorly differentiated or signet ring cell carcinomas, which are not FDG avid. So it's better to do diagnostic laparoscopy to rule out any peritoneal metastasis. Also, if there is any peritoneal metastasis, we can, expeditiously change the plan to palliative if there is a PCI score of more than 7. If the PCI score is more than lab PCI score is less than 7, so we can plan CRS HAPEC along with the major surgery.
Thank you so much. So, Dr. Caleb, I have a question for you. In case of, if we are deciding after pre-neoadjuvant chemotherapy, if we are deciding to go ahead with a open surgery or laparoscopic surgery, so definitely there is no question of having a staging laparoscopy again prior to surgery. So actually in actual practice, how many percentage of patients which were negative before starting neoadjuvant have actually become positive in peritoneal metastasis prior to surgery after neoadjuvant chemotherapy?
Yeah, it will be less than 10%. But what is important is that even if you pick up a metastasis, it will be difficult on the laparoscopy to say that it is actually a metastasis. It will not be very easy because you might find some lesion which might be just a healed scar or other lesions also. It may not be very easy to identify in the post NACT setting. So
thank you so much, sir. So as all of our panelists stick to the same point, this is just a figure that NCCN also recommends this preoperative, before preoperative neoadjuvant chemotherapy, we should do a staging laparoscopy. It can change some management in around 13 to 37% of cases. Plus it helps in assessment of peritoneal cytology and laparoscopic ultrasound also. Now, this is again all locoregional in medical fit surgically resectable patients. We have to consider a diagnostic laparoscopy with cytology. So this is one article I have come across in which they have actually conducted this study. They have given neoadjuvant therapy, then they have restaged the disease, and then they went ahead for a surgery. Before surgery, they again did a staging laparoscopy. So in that, they have found around 7.3% of patients, they had occult M1 disease. So yes, this should be a norm that prior to surgery, we should do a second laparoscopic, staging laparoscopy. So this is the PET CT of that patient in February 2020. This is pre-chemo and post-chemo. We can see there is a partial response to chemotherapy, as the lymph nodes and even the growth has slightly decreased in size. So Dr. Caleb, what is your next step in this patient?
Yeah, we'll plan for the surgery. And before surgery, most importantly, I would like to look at the nutrition of the patient. Nutritional, in fact, we initiate the nutritional improvement from day one once the patient comes. So that is an important part in GI surgery, which we need to remember, and assess the albumin levels also, and then take up for surgery, counsel the patient for surgery. And generally, we do open surgery as of now, being the standard of care here. So, and because we see most of locally advanced, so of course with the laparoscopy, yeah.
So what type of surgery would you consider in this case?
Yeah, because it's a distal growth, I will go for a distal subtotal gastrectomy, and with a D2 lymphadenectomy.
Okay,
so we'll aim for a one at the distal margin. Usually I try to take it at the I mean, there was some discussion about the margins as to what is there any delineating feature for the margins. So for the distal margin, usually we take just above the anterior to the gastroduodenal artery. So the gastroduodenal artery is just behind the pylorus of the stomach. So I mean, usually it may not be very safe to go distal to it. So usually we fire the stapler just anterior to the gastroduodenal artery. That will be a good point to take the distal margin. And then proximally, obviously, we'll get at the where the gastroepiphyloid end and the short gastric starts. That is a point. And we have to remember that always the lesser curvature, entire lesser curvature needs to be removed in any kind of gastrectomy, because we want all the lymph nodes to be cleared from there. And usually we still follow doing a vasectomy and removal of the entire omentum, like Dr. Chandramohan said. But with the advent of laparoscopy, most people feel that the vasectomy can be left out. But then in an open surgery, I don't think the vasectomy takes any extra effort, and usually we do carry on with that also.
Thank you so much, sir. Actually, you've answered many of my questions, which are there in the slides later on.
Sorry.
So that's okay. Dr. Shaifali, what are the broad oncological principles in cases of surgery related to cancer stomach?
So yeah, in this case, adequate margin, R0 resection along with D2 lymphadenectomy. And as Dr. Harris said, we divide just interior to gastroduodenal artery. So that includes around 1 to 2 centimeter of D1. So generally the stomach cancers don't infiltrate duodenum because of anatomical location. On CT, though, they appear to be involving because of the hanging of the tumor, but in intraoperatively, we hardly find any tumor involving duodenum. So, obviously the proximal frozen margin should be negative.
Excellent.
We don't do vasectomy because it hasn't shown any survival benefit, and we do total.
I have slides for that also.
Okay.
Thank you so much. So, Dr. Chandramohan sir, would you like to consider laparoscopy versus open? What would you prefer at your center? In most of the cases, whether it is distal gastrectomy or total gastrectomy, this is not pertinent to this case only.
So my answer is a very long answer, because we have very fantastic GI surgeons doing lap in Kerala, and none of them are very comfortable in doing stomach. The reason is that they think that, by doing a lab, there is some compromise on the radicality. In fact, one surgeon has done many laparoscopic Whipple's operations, but he thinks that stomach cancer has to be done open. And I respect that view, because you don't get the pleasure of dissecting each artery and taping it and seeing it, then removing all knots. Whether that is required is the next question I am facing. So such kind of surgery is required in a specific subset of patients when you have a very limited nodal disease. So either when you have extensive nodal disease, either your disease is going to be a little advanced and nothing is going to work on the patient. And when you have very less nodal disease also, it is not going to be needed. But when you have a node sitting along that artery, that station behind, maybe in 8P or somewhere, then this is going to be helpful. But how many patients come to that subgroup, I don't know. And again, don't compartmentalize things into open surgery, laparoscopy. I think this has to be used whenever you need it. For example, I started doing laparoscopy, diagnostic laparoscopy first, and then started mobilizing. I have found out that the dissection of the crus area is excellent with the laparoscopy. The incision length is much less laparoscopy. Then you can have a very good dissection of the station 8A, station 9, station 11P with the laparoscopy. So, and this is also what we do in esophageal cancer. And this we can do it really fast. But I think that if once you dissect the greater curvature area where you don't need much of lymphadenectomy, especially in short gastric area, then after going the crus and dissecting everything out, and if you feel that one area need to be dissected further, I think while doing the conversion incision for making that stomach tube, you can easily do that. So when you have the capability and machinery for laparoscopy, do it, because I regret going back to the patient after an open surgery and say it was inoperable because it was stuck to pancreas. So I make it operable everywhere, dissect out all nodes possible, and then open, and some nodes are left behind. With a small 5 cm incision, I remove it.
Thank you, sir. Does it have anything to do with the surgical volume of the institute also, sir?
Yeah, actually, when you have volume, I think you ought to do more open, but our volumes are high, but even when I am pursuing the laparoscopy.
Dr. Rajesh, sir, at AIMS, what do you prefer to do?
We do open for gastric cancer, not because that we consider open it's because of logistic issues. Laparoscopy, I think, can be done for gastric cancer. It depends upon the expertise of the surgeon. If they can do the same surgery you have to follow the oncological principles, and if you can do that laparoscopically, you are skilled enough, then for sure. But you should not compromise the radicality of the surgery for doing the laparoscopy. That is a message.
Dr. Caleb, at your center?
Yeah, I mean, I've right now I'm doing only open, so maybe in due course probably I'll start doing. I mean, I've done maybe when what my idea is that maybe probably I should do more like for esophagus abdominal mobilization. The more we do, the more we improve our more my skills will improve, and then when I'm confident of good oncological clearance, probably I'll do stomach.
Thank you, sir. And Dr. Shaifali at Rajiv Gandhi?
We are doing mostly open, and we have started doing robotic surgery. But yes, if the surgeon is comfortable and if you can achieve a good oncological outcome with adequate lymphadenectomy, why not? You should go for it.
So definitely laparoscopy is better than open, but not at the expense of leaving some gross tumor or lymph nodes behind. Dr. Chandramohan sir, do you, during the laparoscopic procedures, do you do the reconstruction also laparoscopically, or you have to open for that?
You can do it only, again, the issue you raised initially, the workload comes. So I need to do either 2 or 3 GI cases in a day. If I do reconstruction also, I am going to do only 1 case. So that's my limitation.
Okay. So there's this recent article in Journal of Surgical Oncology in 2020. They have obviously concluded that laparoscopy is any day better than open surgery in terms of lesser intraoperative blood loss, quicker recovery with lap surgery, along with similar surgical oncologic outcomes. And there are some class 01, class 02 trials also. There are Japanese and Korean trials. All of them, the Chinese surgeons, they have in this particular article, in this particular trial, they have included around 1,039 patients. And for locally advanced gastric cancers, they have compared laparoscopy, distal gastrectomy versus open. They did not find that laparoscopy was inferior to open in terms of disease-free survival at 1 year and 3 years, and also in terms of locoregional recurrence. Now, extent of resection. Dr. Rajesh, so the proximal and distal extent of resection, how do you decide intraoperatively?
So distal is straightforward. You have to divide in the first part of duodenum. You can divide 1 centimeter to 2 centimeters distal to the pylorus, and most of the time you'll get a negative margin. Proximally, if it's a bulky tumor, you have to go at least 5 centimeters proximal. We tend to send both proximal and distal margin for frozen section and proceed accordingly. If the proximal margin is positive, then you resect further, and sometimes you have to convert a subtotal to a total gastrectomy. Distal margin, we have got positive only once so far. So all of the time it was negative, and that in that case also we could resect further and get a negative margin. So distal margin is usually easy to get. Proximal margin we may get positive, and then we'll have to resect further depending on that. But gross margin of 5 centimeters for bulky tumors, and for small tumors we can go to 2-3 centimeters proximal margin and confirm with frozen section.
Thank you, sir. We all agree to that. So, Dr. Shaifali, the resection margins, can you just elaborate for all T tumors?
It said that the reports that T1 needs 2 centimeters, T2 needs 3 centimeters, and more than T2, it's 4 to 5 centimeters. NCCN says 4 centimeters. Now they say that they should be macroscopically negative margin, of which is about 4 to 5 centimeters. But generally we get patients with locally advanced disease, which is more than T2. So we generally take it to safer side to keep it 5 centimeters, 4 to 5 centimeters.
Does it have anything to do with the histology of the the type of histology of the cancer? If it is
definitely. The tumor is poorly differentiated with signet ring cell and linitis plastica type of picture, we generally go with the total gastrectomy, because there are skip metastasis in some mucosa, lymphatic metastasis. So generally, even if you get a negative margin, the probability is there is some skip metastasis proximal to that. So we generally go for total gastrectomy in such cases.
So T2 tumor with a diffuse variety of carcinoma stomach, still you will consider a proximal resection margin of 3 centimeter or 5 centimeter?
I will go for total gastrectomy in such cases.
Okay. Dr. Chandramohan, sir?
I think this is perfectly answered. My concern is not total gastrectomy. When you have a tumor at the upper end or O junction, then my concern is to convert it into esophectomy. That's what I advise. Otherwise, these are perfectly okay. So a proximal tumor, whenever we went compromised in a deep infiltrated tumor for a margin less than 5 centimeter, they all recurred. Thank you.
Thank you, sir. So in cases of mid and distal gastric cancers, what surgery do you prefer, Dr. Caleb?
Yeah, I'll go for a distal subtotal gastrectomy. At least like around 2/3 of the stomach, we'll take it off. And like I said, the distal end is at the anterior to the gastroduodenal artery, so that we can't. It's at the D1 actually, and proximally at the interface between where the short gastrics start at that level. So by that we'll get almost 2/3 of the stomach out and the entire lesser curvature. So that's how the margin is. And like others said also, if the margin proximal is positive at that level, then probably I'll convert it to a total gastrectomy.
Okay. So, sir, basically, what is the difference? Is there a term called distal gastrectomy and subtotal gastrectomy? They are different terms or they are equal? And if they're not equal, then what is the difference between them?
I mean, I'm not. I mean, I have always what my understanding is that it's always a distal subtotal gastrectomy. So, I mean, I don't see anything less than that because we have to clear the lymph nodes anyway completely. If you take anything less than that, the lymphadenectomy may not be adequate, especially for the kind of cases we see, which are anyway more than T3 in general.
So in distal gastric cancers, the minimum should be a distal subtotal gastrectomy.
Yeah.
So you're right. Actually, subtotal gastrectomy is actually the treatment of choice in cases of distal and mid-gastric cancers to achieve a proper R0 resection. Two RCTs have also conducted. They have showed no added survival benefit for a total gastrectomy for distal cancers in compared to a partial gastrectomy, that is subtotal gastrectomy. So, Dr. Chandramohan sir, in proximal gastric cancer, do you prefer at your center proximal gastrectomy or a total gastrectomy?
I just answered. I am against proximal gastrectomy. It has to be more than total gastrectomy. Well, I am worried about the esophageal margin. If you can't get the 5 centimeter margin in esophagus, better to make a stomach tube and do an esophagectomy with the proper lymphadenectomy of the stomach.
Okay, sir. So this is a sir. Actually, I wanted to ask, what is the difference between doing a proximal gastrectomy and a total gastrectomy? Why do you prefer a total gastrectomy over a proximal gastrectomy?
To me, the number one, the complication you just projected. So I was describing there are two sphincters, proximal as well as distal. So when you do a proximal gastrectomy, you are taking away the proximal sphincter and keeping the distal sphincter. That causes obstruction against the closed pyloric valve and route of reflex. So that is going to create issue. And anastomotic stricture is the next issue. And the most important thing is you are not addressing the distal level 5-6 nodes. So that causes recurrence. So oncologically as well as functionally, it is bad.
Excellent, sir. Thank you. So now we are coming to a margin frozen section, which we were just talking about a few slides back. So do you all do routinely a proximal margin frozen section in all your cases, proximal and distal? Dr. Chandramohan, sir?
No, I don't do. And it is, when you have, I don't do because of logistic issues. It is, if you have, you use it. Because many times, again, not distal. Distal, it is not, it's that harmful. Proximally, many times you will have a submucosal spread and the skip lesion, it will recur. Then again, I am not doing frozen to not prevent recurrence. The recommended margin is not negative margin. The recommended proximal margin in deep infinity tumor is 5 centimeter margin. The frozen is not going to tell you that. Only thing is that the frozen section will tell you a positive margin that can be avoided. Number two, medico-legally, it will make your practice safe.
Okay. Dr. Rajesh, sir?
We would tend, we would do a routine frozen section.
Dr. Shaifali and Dr. Caleb, at your centers?
Yeah, as long as it's logistically possible, I do it. Of course, if you're doing operating a second case late in the evening, being a government hospital, I may not have the availability. Otherwise, I do.
Even in private hospitals also, after 5 o'clock, there is no one to do a frozen section. So, Dr. Shaifali?
We don't do if we are getting a 5 centimeter margin, but if it is less than 5, we do a proximal frozen section, but not the distal one. We don't do distal one because we are on duodenum 2 centimeters beyond. So generally we don't do.
Okay, so we all come to a common consensus. Dr. Chandramohan sir, I just wanted to ask if, have you ever come across a distal gastrectomy patient in which a distal frozen section or distal margin later on after final pathology biopsy has come positive?
I think once, so I have been operating for the last 20 years and once only that occurred, but proximal margin many times.
So, sir, if on table we are sending a distal margin frozen section, and if comes out to be positive, then what would you recommend to do?
Redo another margin, and that is going to make you safe. And I don't feel the extended pancreatoduodenectomy have a place in managing the carcinoma stomach. So get 1 centimeter more margin, that should be enough. And also look into the aggressiveness of the disease. If the disease is very aggressive, with a lot of lymph nodes around, and I don't think you are not going to get any advantage by getting on 1 centimeter more of disease. So it's a very limited disease, very limited cases only you get advantage.
Thank you, sir. So in 2020, this article I've come across, they have said that proximal margin of 3 to 5 centimeter, as we have all discussed, they routinely send for a frozen section. But point well taken from Dr. Chandramohan sir also, that if we are getting a proximal margin of 5 centimeter, then it should be more than enough. Now, coming to the lymphadenectomy, the most important aspect in cases of in terms of surgery related to carcinoma stomach. So, sir, Dr. Chandramohan sir, in total gastrectomy, just can you put some light on D1, D2, and what is extended D2 or D3 lymphadenectomies? I mean, so what are all the stations?
As I mentioned in my talk, the total gastrectomy involves the D1, you have to remove all perigastric lymph nodes plus 7. And in D2 gastrectomy, you concentrate on more on the stomach, the nodes which is on the left upper quadrant. So you go remove more of the splenic artery nodes. Then the station 1 and 2. When the tumor is located on the greater curvature, or you have a node positive at 4SB, then you go and do the splenic hilar nodes. So I think there is a question to me. Total gastrectomy.
Yeah. Yes, sir. And in distal gastrectomy, Dr. Rajesh Panwar?
So in distal gastrectomy, I'll divide the lymphadenectomy on the lesser curvature. You have 1, 3, and 5 on lesser curvature. So you have to remove all. On greater curvature, you leave behind the left pericardiac, that is 2. Then you will leave behind the short gastric also, that is 4SA. You start from the left gastroesophageal. You have to remove 4SB, and then you have to remove right gastroesophageal, that is 4B. And then you have to remove infrapyloric, that is 6. Then you have to go on the vessels. 7 is the left gastric. You have to remove then common hepatic artery. 8, the celiac axis 9, and then proximal proximal splenic, that is 11P, and then anterior hepatic, that is 12P. So that will complete your D2. D1 will be only perigastric, that is 1, 3, 5, and the 4SB, 4D, and 6. And anything between D1 and D2 will be D1 plus.
So thank you, sir. So this already Dr. Chandramohan sir has presented in his presentation. So latest journal, this Association Gastric Cancer Association 5th edition, they've removed this splenic hilar node dissection from this D2 lymphadenectomy for total gastrectomy, and it has to be dissected only if there is greater curvature growth or there is a lymph node sitting right there. Now, this is again the total gastrectomy. I'm again and again putting all these slides about lymphadenectomy because the lymphadenectomy is the only thing which has, I mean, D2 lymphadenectomy has revolutionized actually the gastrectomy procedure. So in total gastrectomy, station 10, that is splenic hilum nodes have been spared. And in distal gastrectomy, as Dr. Rajesh has clearly mentioned, the station 2, 4SA, that is the short gastric vessels, splenic hilum, and the distal splenic nodes have to be spared. So, Dr. Caleb, at your center, what do you think the difference between the outcome between D1 and D2 resections?
Outcome, I mean, I won't be able to back up with the data because we've been doing, I mean, I've been trained in D2 only. I've never done a D1. So, I mean, I won't be able to tell a difference as such. And even otherwise, if you're trained enough, I think it hardly takes maybe some 20 to 30 minutes extra to complete the full lymphadenectomy, because while dissecting also, it is easier to, I mean, confidently take out the left gastric only if you see the vessels. So I feel it's quite comfortable. I mean, I'm much more comfortable doing a D2 rather than a D1. So it's always been a D2.
Complication rates are higher with D2. The morbidity, post-operative morbidity is higher in D2 versus D1.
I won't agree with that, because I think whatever literature says about the increased morbidity pertains probably to the, I mean, with the Western settings wherein people had lot of splenectomies and pancreatectomies. But I don't think when we are doing a surgery sparing the pancreas and the spleen, I don't see much of complications, any added complication apart from a D1.
Right, sir. So this is a Dutch D1, D2 trial. It's a huge trial. They have done a 15-year follow-up. I'll just summarize this. They have actually concluded that this overall survival between D1 and D2 gastrectomies was statistically not significant. There was no difference between the D1, D2. However, in cancer-related death was seen higher with a D1 lymphadenectomies. And death due to other causes like postoperative morbidity, mortality were more in cases of D2 lymphadenectomy. So the majority of the morbidity data after D2 lymphadenectomy in the Dutch trial was because they have, at that time, they were including distal pancreaticosplenectomy, like resection of the pancreatic tail along with the spleen in all two D2 resections. So that might have resulted in increased morbidity in cases of D2 lymphadenectomy. But however, as Dr. Chandramohan and Dr. Caleb both have mentioned, that the D1, D2 per se, the morbidity is not that much different between the two stations, between the two procedures. Now, Dr. Shaifali, what about D3, that is extended D2?
D3, like involving removing para-aortic lymph nodes and extensive dissection of HDL, we don't do it, and it's not recommended also. It is not shown to improve overall survival. So we don't do it routinely in every case.
So yes, D3 is the extended lymphadenectomy, which involves a para-aortic lymph node dissection. They have shown recent Cochrane analysis. They have shown 3 RCTs. They have said that resection of the para-aortic nodes did not provide any significant survival benefit. So, Dr. Rajesh, what are the indications of D1 lymphadenectomy? In which all cases can you go ahead with a D1 lymphadenectomy only?
I think only very early gastric cancer, but we don't get, you'll get those cases only if you have a upper GI screening program like they have in Japan. We get patients who are already T3, T4. So in those cases, D1 is not good enough. So if you have an early gastric cancer, or you are just doing a palliative kind of a resection, then maybe you may omit D2, but otherwise the D2 is the standard.
Dr. Chandramohan sir, have you ever done a D1 lymphadenectomy in some other patients in some special situations?
Really, I don't advise for malignancy once you are diagnosed from a cancer. And the issue here is very difficult to differentiate T1 A from T1B. From T1B onwards, you need to have a D2 lymphadenectomy. And we don't routinely do endoscopic ultrasound. And most cases, as Caleb has rightly pointed out, are advanced cases only. So when you have a patient and you have a small ulcer, you have done endoscopic ultrasound, it is showing T1, just mucosal disease. Then, and if you are not doing an EMR, you can do a D1 lymphadenectomy. Other than that, I think all other cases, other than metastatic, has to undergo a D2 lymphadenectomy.
So, sir, actually, I had not found any literature regarding that, but I remember I have heard from some presentation only that in some cirrhotic patients, in some selected patients, we can go ahead with a D1 lymphadenectomy. I'm really not sure whether I should quote it or not, but what is your opinion about this?
Should be, because in a cirrhotic, we'll have issues with the upper abdomen. But again, I don't see that kind of hardly for a D1, D2 make much of a difference with our patients. You know? It will hardly take maybe half an hour, 45 minutes, and I don't think there's a great issue for Indian patients. But maybe in Europe or in UK, they have issues. But otherwise, for all patients, even if they are mildly cirrhotic, go ahead with D2 lymphadenectomy.
If a cirrhotic has lots of collateral, then you may not be able to do a D2 gastrectomy.
Okay, sir. Now, Dr. Rajesh, what about partial pancreatectomy and splenectomy? It should be, if at all required, it should be done, or it should be preserved.
So many times we have to do this procedure because in proximal gastric cancer, where there is direct infiltration of pancreatic hilum or spleen. But if it is not directly infiltrated, then you should not be resecting just for lymphadenectomy. So you can do lymphadenectomy without removing the spleen and distal
Does
pancreas.
it add to increased postoperative morbidity?
Yes, it does. So the distal, if you do a distal pancreatectomy, the chances of a pancreatic fistula, which is very, very common, 20-30% will have that. And once they develop postoperative complications, then you want to give adjuvant therapy also, it also get delayed, and all those things become important. So pancreatectomy should be reserved only for patients who have direct involvement with because of tumor.
Okay, sir. So, Dr. Shaifali, have you come across this sentinel lymph node biopsy in gastric cancer? What are your ideas about this?
No, I have not come across sentinel lymph node biopsy because we don't see early gastric cancers. Basically, sentinel lymph node biopsy is for early gastric cancers where you can do function preserving gastrectomy. So I have not come across that because we generally don't see early gastric cancers and we don't do sentinel lymph node biopsy at all.
Does anyone follow this? I don't think anyone should be following because they've clearly mentioned that sentinel lymph node biopsy has a very high false negative assessment. So it cannot reliably replace lymph node dissection. Now, Dr. Caleb, what about omentectomy as a routine procedure?
Yeah, omentectomy, I will go ahead as a routine procedure. And I think most recommendations also are for completing the omentectomy. Unless if you're doing a very early cancer, maybe you can just do part of it. But otherwise, in general, you have to remove it.
And Dr. Caleb, what about vasectomy?
Yeah, we usually go ahead with it. But as discussed, for laparoscopy, with the advent of laparoscopy, it has stopped. Maybe we need long-term results to actually get to understand. Yeah.
Thank you, sir. So now we are coming to the last part, that is the reconstruction. In total gastrectomy, after total gastrectomy, what do you prefer as a reconstructive procedure? What are the options and what do you prefer at your center? Dr. Chandramohan, sir.
So I do Roux-en-Y and when
you don't consider, sir, jejunal pouch reconstruction?
No, we have not done, and I don't think any advantage in literature for jejunal pouch.
Dr. Rajesh?
Yeah, you may find that in literature, but I don't think any of us have performed a jejunal pouch reconstruction for a gastric total gastrectomy. We also do a Roux-en-Y hand seal esophageal gastric jejunal.
Thank you. Dr. Caleb, at your center?
Yeah, same Roux-en-Y.
Dr. Shaifali?
We also do Roux-en-Y. We don't do pouch.
Okay. And in distal gastrectomy, generally, we follow gastrojejunostomy. I think all the panelists must be following it. So this gastrojejunostomy Wilbur 2 procedure, you prefer Roux-en-Y or a loop with bronze jejunostomy? Dr. Chandramohan, sir.
I think I again do Roux-en-Y and sometimes loop.
Dr. Rajesh? So we did a study around 5-10 years back on this. So in that was a prospective study and it was not a randomized study. So I think we found that we were doing Roux-en-Y for subtotal gastrectomies for curative resections and loop for the palliative or a palliative gastrectomy or a palliative bypass. So our take is that it's going to be longer survival, then probably you like to do a Roux-en-Y. Otherwise, if you want to do just for palliation, you can do a fast procedure by doing a loop in gastroesophageal.
Dr. Caleb, at your center?
Yeah, I usually do a loop with a bronze JJ. But sometimes if there is a lot of time, then I'll do a Roux-en-Y. Depends on the OT timing.
And Dr. Shaifali?
Few years back, we were doing Bilrod too, but we saw a lot of medical treatment-resistant bile reflux patients with untractable bile reflux. So we have changed our practice to Roux-en-Y now.
So is it advisable to add a bronze jejunostomy in cases of loop gastrojejunostomy?
I don't know. We are not doing it.
Chandramohan, sir.
If you are doing, I think it is okay, but it can be omitted also. Both are okay.
I think no patient of yours have complained of reflux after this. Thank you, sir. And what about the esophageal anastomosis after total gastrectomy? Whether you prefer it hand-sewn or stapled, and of course laparoscopy open, that is a separate debate. But do you do a hand-sewn anastomosis or a stapled anastomosis?
I do always stepping, circular stepping.
Circular stapler. Dr. Rajesh?
We do hand-sewn interrupted analysis.
Dr. Caleb, at your center?
I've always done a stapled 25 mm.
And Dr. Shaifali?
We have done both hand-sewn also and stapled also. To save time, we are doing stapled more now.
Which do you prefer? I mean, any stricture rate or something like that? Any
We have
difference
not
between
seen any higher structural rate with the stapled anastomosis also. Both are same. No leak, no change in leak rate or stricture rate.
Thank you. So, sir, Dr. Chandramohan, sir, after a total gastrectomy or distal gastrectomy, do you keep a nasogastric drainage routinely, even after a total gastrectomy?
Yeah, I think this is a debatable issue, and as we advance in the patient care management and the eras, this should be discouraged, and this is discouraged in many countries, but still we are behind. We are keeping it.
And in distal gastrectomies?
Both.
Dr. Rajesh?
We are a bit more conservative in this issue. So we'll keep a nasogastric nasovaginal tube for 7 days after a total gastrectomy. For distal gastrectomy, we'll see on day 1 if output is less than 200, then we can remove, otherwise we'll see.
So after a total gastrectomy, if you are putting a nasogastric tube, is there any fixed time whether you when do you remove it? I don't think there is a certain advantage of putting a Ryle's tube after a total gastrectomy. So when do you remove, sir?
So we do a contrast study on day 7. If there is no leak, then we remove and then we start over.
Okay. Incision for specimen retrieval. This is my personal question. So whether it is a midline incision you prefer after a laparoscopy, after laparoscopic surgery for this specimen retrieval, do you prefer to have a midline incision, or a phalansteal incision can also be sufficient because it also adds to, I mean, less scar and all? Dr. Chandramohan, sir.
If you're doing a full laparoscopic anastomosis, I think phalansteal is good enough. But since we are not doing it, we are putting a small 5 centimeter midline incision above umbilicus. If you are fully doing everything anastomosis, and you can even remove it transvaginally, and so sometimes then you can endoscopically you can remove. These are all various options.
Our centers are preferring phalansteal incision, because if we are doing total laparoscopy reconstruction and resection, then we are giving a 5 centimeter lower abdominal phalansteal incision. So, Dr. Chandramohan, sir, what about liver resection in treatment of oligometastatic gastric cancer?
It is not recommendable, but you can do if you have MDT things like. But I don't recommend it. But suppose say one small nodule sitting it, we can take it out for whatever advantage, but otherwise it's not recommendable.
Any other panelists who would like to differ?
Yeah, you can do, but in very, very selected patients who have received chemotherapy and then they have a they have a isolated liver lesion, then probably you can do, but not as a routine.
Okay, so this is actually not a norm. I mean, this is not a recommendation to do a hepatic resection in cases of liver metastasis, in cases of gastric cancer. But in some countries they are following it. They want to have a prospective trial on this. So this is one of the trials. In this, they have divided actually into 4 groups. The group 1 is gastric cancer, in which there is no liver mets. The group 2 has with liver mets, for which they have done both gastrectomy and hepatectomy. In group 3, they have done gastrectomy, but there was liver metastasis, but they have not excised the liver. And group 4 was they have not done any surgery. So they have found out this Kaplan-Meier survival. As you can see, the survival curve is more with hepatectomy and gastrectomy in cases of oligometastatic liver disease. But this is not a recommendation. This has not become a recommendation till now. So, Dr. Rajesh, do you want to put some light on HIPEC for gastric cancer in cases of carcinoma, peritoneal carcinomatosis?
We have tried it. We have done a small study, around 22 patients. Most of them were advanced gastric cancers. 15 were T4 and 7 were T3. And one had a few METs also, which were underwent a cytoreductive surgery. So we gave mitomycin-based HIPEC in these patients. So far, these are early results. There was one post-operative death and 3 patients died further. So 18 out of 22 were surviving at a median survival of 9 months. So only around 8 patients have completed 1 year and 1 year survival. So it's early results. So it may be considered for advanced disease. Right now, we don't have a definitive answer. But if we get long-term results, then it may be a promising therapy, especially for oligometastatic gastric cancer. Right now, oligometastatic is a contraindication for surgery, but in future it may become a resectable disease if HIPEC turns out to be good.
Okay, sir. Thank you. So I think there's shortage of time. I'll just run through the slides. Dr. Shaifali, any role of surgery for palliation in cases of CS stomach?
Yes, only if the patient has emergency conditions like bleeding, obstruction, or perforation. In case of bleeding, we generally try all other measures like endoscopic injection of adrenaline or argon beam or radiation. But if it is life-threatening, definitely then palliative resection has a role.
And in obstruction, do you
mostly if it's a advanced disease and we suspect that the life of the patient is less than 3 months, we go for enteral stenting. If the PS is good and we expect a longer outcome in those patients, we go for gastrojejunostomy then.
Okay, Dr. Chandramohan sir, in cases of obstructed symptoms, gastric outlet obstruction, do you go ahead with a neoadjuvant chemotherapy or directly surgery?
If you have a obstruction, I think it is very difficult to start chemotherapy when the patient is continuously vomiting. And if it is not a metastatic one, we go ahead with a proper lymphadenectomy, if possible, and then give that later on.
So, sir, suppose a T3N0 tumor is there, and the patient has been in gastric outlet obstruction. He's vomiting all the time since last 2 weeks. He has lost quite a weight. So, in that case, would you consider putting a stent for some time, build him up nutritionally, give some chemotherapy, and then do a surgery, or directly go ahead with the surgery?
I will directly go ahead with surgery because number one, the stenting is not going to be that useful many times. So it is not recommendable in carcinoma stomach. The failure is very high. And number two, many of the principles in the oncology, we are sacrosanct is not so important. Like all patients, there are certain exceptions also. If actually, in fact, I was reading Dr. Ramakrishnan from Adyar Cancer Institute has done a propensity-matched analysis of locally advanced breast cancer, stomach cancer undergoing open surgery, primary surgery versus neoadjuvant protocol, and the survival difference was not much. So this is one definite scenario where you have an obstructed patient, operable patients with little advance. I will go ahead with the deep gastrectomy. I don't think the overall survival is not going to be much. Rather than trying stenting and giving neoadjuvant and failure of the stent, and this is an issue.
Thank you, sir. So coming to the last slide, some yes/no question. Frozen section, Dr. Rajesh, proximal and distal, always you would recommend? Yes,
yeah, for total always, and if time permits, then we always send for a subtotal or distal resection also.
Okay. Dr. Chandramohan sir, if on table you have sent, suppose you don't send a proximal and distal frozen section, but suppose you have sent a distal frozen section, it has come out to be positive, and you have to go ahead with a Whipple on table. You have to decide. Otherwise, you won't get a margin negative resection. What would you go ahead with a Whipple or not?
Mostly no. Mostly no. It's very rarely yes.
So then in that case, you just prefer to give a adjuvant chemoradiography.
No, I looked into the other aspect. You know, how bad is the proximal lymph nodes? How bad is the lymph nodes around? How aggressive is the disease? And in a disease which is failing everywhere, defeating you everywhere, there is no point going and causing extra morbidity of the people. But if it is a focal point, very well differentiated disease, otherwise controllable, only this is only abnormality, then I may think, otherwise not.
May I add something here?
Yes, sir.
Yeah, so here duodenum margin is generally never an indication for Whipple. One indication for Whipple in this situation would be when your tumor is stuck to the pancreatic head. Sometimes that can happen, and in those cases, you may need to do a Whipple.
Sure, sir. Thank you. Dr. Caleb, early gastric cancer, would you prefer a surgery or an endoscopic procedure?
Yeah, if it is possible, if the criteria are met, like T1 lesion and sure the certainty of nodes being, not involved, then probably we can consider if the facility is there. But otherwise, we'll go with surgery. And in our setting, I don't have access to the facility, so we go ahead with surgery only.
Dr. Shaifali, you said you're nowadays doing robotic surgeries. So, do you find EJ anastomosis better with lab or open or robotic?
Open is definitely better, and we do stapled, so it's definitely better and less time consuming.
Thank you, all the panelists. So, I'm just concluding this panel discussion. There are just some take-home messages. Gastric cancer has been the second most common cause of cancer-related deaths among Indian men. Staging laparoscopy to be done in any N-positive disease or more than T2 or higher, both pre-operative, pre-neoadjuvant and pre-surgery. Surgery has to be laparoscopy or open. Laparoscopy is definitely preferred, but not at the expense of positive tumor leaving behind. Adequate proximal and distal margins with or without frozen section, and surgery with a proper D2 lymph node dissection, whether it is laparoscopy or open. It is the primary treatment option for medically fit patients. And reconstruction definitely as appropriate in our centers. We have to do this. Thank you so much, all the panelists. I take this as a privilege to be with you all. Thank you so much.
Thank you, Subhashish. Thank you. It was a very good discussion, and you have brought out all the pertinent points there. I think Dr. Vivek Mangla wanted to say something about pouch reconstruction. Dr. Vivek.
So what I wanted to add was that pouch, actually speaking, it is something which has remained underutilized despite the fact that literature does support its use in selected patients. So for example, patients who are expected to have good survival, that's a group of patients in whom probably the pouch adds, because what it ends up doing is it adds up to the fact that the patient can take more diet orally. And in the long term, the return to normal activity and weight maintenance is also easier with these patients. And technically speaking, when most of us are doing a Roux-en-Y reconstruction, the difference in making a pouch is just adding 2 stapler cartridges and keeping the Roux-en-Y a little longer, and doing your esophageal anastomosis a bit proximal to the end, and just firing 2 staplers across, and that actually ends up doing the pouch. So in terms of surgery, it doesn't really add much. Maybe around 10-15 minutes of total time would be added to adding a pouch. And we've added in some of our patients, we've actually gone ahead and added it in laparoscopy as well. And it has worked well in both open and laparoscopic surgery. So this is something which I feel is kind of underutilized thing, and it doesn't really add much to the operating time. The first time I did it, I thought it must be something big, but you fire 2 stapler cartridges and the pouch is done. So that's just my take on the pouch, and that's what I wanted to add about the pouch. Thanks, Nikhil, for the letting me say.
Thank you. And I think we need a little more discussion on these patients with gastric outlet obstruction, whether we should give them chemotherapy or surgery. I think some of the people are of the view that these patients can receive neoadjuvant. Amit wanted to say something regarding this. Amit, can I have your views there?
Nikhil, thanks for the opportunity. Just a thought process, not that I've been doing a feeding jejunostomy, but I have seen a couple of cases being done on the surgical onco side, in which set me thinking that, perioperative chemotherapy is the standard. So if these patients present with obstruction, and we go ahead and do a diagnostic laparoscopy and add on feeding jejunostomy, it gives the patient an opportunity to receive the neoadjuvant therapy, which will be close to the standard what is there. So that's my thinking aloud, if I can say. So I would like the opinion of the audience. If they would like to talk on this.
So, Dr. Amit, Dr. Chandramohan has already said that, I mean, the difference of neoadjuvant isn't great. And then if we look at the logistics of these patients tolerating chemotherapy on some jejunal food, or like say, for an example, I have once done it NJ feeding and then neoadjuvant, but there was a doubtful metastasis in ileal bone in that patient. So, matlab, the logistic of giving chemotherapy with jejunal feed, especially flot. So see, the advantage of neoadjuvant will come with flot. Now, flot you cannot give to a suboptimal patient, right? So, so they're giving half-hearted neoadjuvant chemotherapy doesn't help. And I would rather go ahead and resect this patient. I would want to have other views as well. So sorry, Dr. Rajesh was telling something. Rajesh.
Plus, there is issue that the patient will continue to have vomiting. So that won't be taken care of by a feeding jejunostomy or an nasal tube. So patient will be symptomatic. So and then because of these chemotherapy, they take a lot on the patient. We know that lot regimen. So it would be very, very difficult. You may choose it, but ultimately, whether you will be able to take that patient, you will be able to give full 4 slot cycles and then take them to the operation theater. That is very less likely in that situation.
So I guess most of the views in the house is that you should rather do an upfront surgery. So there's one more question here. Station 13 node in distal cancer. Anyone want to take that? Dr. Chandramohan?
You have the tumor going to the pancreatic area, and nodes there. For example, infiltration of the pancreas, then session 13 has to be removed. And when you suspect a nodal spread there, in the particular location where the tumor is going to go via the retropancreatic pathways, then you remove it, otherwise it's not needed.
Yeah. And so you said when pancreas infiltrated, that was in the context of feeding jejunostomy and neoadjuvant, that's what you meant? Or
No,
the station 13?
You have this, it's not a frank infiltration. When you suspect the tumor going to that area, and you have multiple nodes positive along the pancreatic area, then session 13 has to be removed.
Yeah. So I think we are done. So I think with this, we can conclude this session. Thank you, everyone. Thank you very much. Thank you for a very wonderful and nice session. Thank you, Dr. Chandramohan, Subhashish, Dr. Harris, Dr. Shaifali, Dr. Rajesh. Thank you, Dr. Vivek and Amit for pitching in. Thank you, everyone, and a very good night.
Thank you, Dr. Nikhil. Thank you so much for inviting us.
Please, thank you.